Hello guys, this is Riyadh, and we basically now today in lecture, I think it's 7, part of cardiovascular pathology, pathophysiology, USMLE step 1. Okay guys, so what we have for today, we have 28, and always you remember the first things is basically the age. She's 28, the second, Mexican, there is something Mexican immigrant, in the heart, always, when he's talking about some immigrant, you have to remember that he tried to refer you that please think about rheumatic fever, at least in the history. All right. So she's female, so this is the reason why he made the descent here. Female patient present to the clinic with the 3 months history of progressive shortness of breath. So basically, usually this progressive shortness of breath, the chronic one, guys, always really it's non-specific. Could it present as valvular heart disease? Could be heart failure. Really, could be whatever. So shortness of breath with moderate exercise. Past medical history is insignificant, except for some joint problem when she was 15 years and treated medically. So I think now is the story clear. So basically, he's trying to tell you that the patient has joint problem when she was 15 years. So basically, the patient has rheumatic fever at that time, treated medically, and since that time, there is no problem. So guys, why he mentioned all of that? In order to tell you that there is factors for the next valvular heart disease. And you need to know this is age 25, and the age when she has the rheumatic fever was the age of 15. That's when you have around 10 years after that. Now, what next? A physical exam showed hollow systolic murmur. I think we need to highlight these in different colors because now he's talking about different stuff. Oh, it's not so nice color, sorry. So it's hollow systolic murmur at the apex that increase by expirations. And any murmur, guys, increase by expiration, usually he is talking about left heart side. Plus, with the murmur, you hear early diastolic heart sound, and you will tell me what is this early diastolic heart sound. There is leg edema, which is basically right heart failure. So this is the issue. Which of the following changes, hemodynamic changes that you would observe? So first, leg edema patient, and here, basically, usually, guys, leg edema, as we are talking about right heart failure, you need to know what is the cause of right heart failure. By the way, the most common cause of right heart failure is left heart failure. But also there are other causes like valvular heart disease in this case, because there is murmur, so you have to think about valvular heart disease here, right? Which is the cause of right heart failure. And this valve basically cause for this patient hollow systolic murmur plus early diastolic heart sound. And then he will tell you these. You remember these, the hemodynamics of yesterday, which is a kind of interesting. Left atrial pressure increase, which is end diastolic pressure, increase left atrial end diastolic pressure, increase the preload in normal pulmonary artery pressure, decrease afterload may improve the symptoms, increase pulse pressures. You have a bunch of. You will not be able to respond to these questions unless you understand the hemodynamic by definitions. We went over some of them yesterday, but we'll run over these again today because really it's important. Now, what I need to tell you that basically it's hollow systolic murmur and the patient have history of rheumatic fever. So basically he's talking about mitral regurgitations, right? So guys, if rheumatic fever in the past, and let's say this is the age of the patient 50 years, and the patient now come to you with 25 years, so basically here you have around 10 years, your diagnosis will be mitral regurg. The same patient, if the age, let's say the patient came with around 35 to 40 years, so in this case, guys, I don't think it's really wise to choose mitral regurg. So here your answer will be mitral stenosis. As I told you, you have to study several of these at the same time, and I will show you how to do that, I think, in the next lectures, because I think by today we'll done with 2 valvular and hypertrophic obstructive cardiomyopathy. I just need 1 for aortic, and then we will really make good lectures for all of them, maybe for 20 minutes. Now, this is the issues. So rheumatic fever, we started as rheumatic fever, usually the age of 15 years, which is basically our patient, and then he told you 25 years, so that's why you have to think about regurg. If it is 50s or 30s, or late 30s or 40, so in this case, you can go further and think about mitral stenosis. So this is the first thing. Second thing about mitral regurg, guys, let's draw the heart, which is as usual. I think I will make two heart. Hopefully, yeah, hopefully there is enough space. So first, this is the heart, and guys, this is the regurg. The problem is this valve will not close. So you can say failure to close, right? Mitral valve during. This is usually the issue here for the student. Now, guys, when you think you need to close the valve, when you have filling or when you need to pump the blood. Just imagine, this is the valve. You need to close the valve when you have already enough blood inside. Why? Because once you will close the valve and you have already enough blood inside, so after that, the blood that's down, which is basically in the left ventricle, will just pump it out. Right? So that's it. So you already here you have enough amount of blood to do systole. Right, which is the pumping action. So failure to close mitral valve during systole, guys. Please pay attention to that. It's really, really big times. This valve will not close during systole. Look at that. The valve is open. Part of this blood, which is here, will regurgitate toward the left ventricle, left atrium again during systole, guys. This is big time. Really, really very interesting. Look at this arrow, which is basically the blue one. Now the blue one represents the regurgitant stroke volume, or if it is hard, because usually I will talk about that in physio. This A part is the regurgitant blood during systole, which is very common mistake. Really, it's very common mistake, and it's really not hard. While the right side is just the red one. The red one is basically the blood that you need to pump it out, or you need to eject the blood out. So basically, guys, you have two pathways. You have A pathway and you have B pathway. Again, it's really, really so high yield, and it's really, really interesting. Now, because of regurgitant blood that goes up, which is totally abnormal, during systole, now what do you think left atrial pressure will be? Really, just think about that. Will not close. And some blood will go, with each systole will go and so basically, the left atrium will be a kind of dilated, and even the pressure on the left atrial pressure will be what? Increase during. This is another question. Systole, guy. Very high yield. Really, I'm telling you, this is very, very high yield concept. Left atrial pressure during systole will be increased because basically you have. Because the valve is not closed, it's just open, and you just keeps regurgitant blood goes and attack the left atrium. That's why left atrium pressure increases during systole. All right, so that's it. Really, the pathophys is really not so hard. You just need to know the principle that everything occurs during systole, and because you have a part, that's why. S1 usually, because S1 is mitral closure, S1 will be faint, right? And after S1, what you hear? What is that? Murmur. Look at that murmur. It's hollow systolic. That means it's not a crescendo, decrescendo, or whatever. It's hollow systolic murmur all over the period of systole. So this is hollow systolic murmur. And if you need more, this hollow systolic murmur sure will be radiated to the axilla. I mean, it's not a big deal because the mitral valve and axilla, so sure will be radiated to the axilla. Because maybe this is a question to differentiate hollow systolic murmur in mitral regurg from hollow systolic murmur of VSD. Hollow systolic murmur of VSD maybe it just left lower sternal border, which is for intercostal space, but usually not radiated. If you need these details. And after that, you get S2 heart sound, right? This is S2 heart sound. So this basically, I hope maybe I'll make another highlight. Yeah, forget it. So this basically, all of that area, I'm not sure why it's not working sometimes. So basically, all of this area, guys, oops, that's embarrassing. All right, now it's working. So basically, all of that area is just hollow systolic murmur, right? Again, go back to the diagram, please. Left atrial pressure increases during systole because you have blood that's pumping up during systole. And we call this regurgitant stroke volume or regurgitated blood. Forget about regurgitated stroke volume if you are not so familiar with that. This will be big questions in physio. Now let's go and make another heart, which is for mitral stenosis, right? Always really, once you compare stuff together, will be really nice. Now look at that. It's totally closed, right? If you remember the mitral, we just done mitral stenosis yesterday. It's totally closed. Look at the blood that not ejected basically. Look at the blood that accumulated here. And because the blood accumulated here, left atrial pressure increase, but mostly during diastole. That's why you will hear diastolic murmur. So you can say, we talked about that yesterday. And look at the ventricular pressure, by the way, here normal or even low. And we said this is basically protected. Why? Because this is left atrial, this is the mitral valve. So the mitral valve is not working. The mitral valve is totally closed. And when the mitral valve is closed, basically the ventricular pressure is fine. I mean, just relax. You didn't have any blood, right? So why you need to suffer? While look at the opposite way. You have a blood here, right? I already started. You have a lot of blood here. Why? Because some of regurgitant also will go down. So you have already blood here. You cannot pump all the blood. That's why left ventricular pressure will be increased. And it's really because after this arrow, you have some blood will go down, right? And you already have some blood there. That's why you will hear a murmur. You will hear a heart sound called S3. Now, big time S3, what I would like you at least here to know about S3 is early systolic. It's early diastolic, definitely. It's early diastolic sound. Plus, S3 means, guys, always early emptying. Early filling, sorry. I mean, because you have already blood down. Why? Because you cannot pump all of that blood. You will get some regurgitant down later on. So basically, it's early filling. Whenever you have early filling, you will hear after S2, a little bit after S2, you'll hear S3. So this is the location of S3. Big time S3 questions, by the way. I think I need to talk about S3 later on in details. But this is just basically maybe because we are talking about part of it. Really very high yield S3 heart sound. Very high yield. So S3 represent early filling. When you have a blood already in the left ventricle, and then you have already their blood, and then blood hit the blood here, this is the hitting part, or this is the hit represent S3 heart sound. Now look at the mitral stenosis pictures. Do you think the blood will go into, where is it? Actually, it's empty. So no S3. This is comparison, right? Look at left ventricular pressure here is decreased, while left ventricular pressure mitral valve and mitral regurg is increased. So these are differences. Let me make the differences by, let me make it a little bit more. So basically look at the differences, guys. Number one. Left atrial pressure increases during diastole, while left atrial pressure increases during systole. 1. Second, left ventricular pressure normal or even low, while left ventricular pressure high. And because left ventricular pressure high, you get S3, so basically no S3. Plus, please, I think I need to make it maybe after one. Please, this A is regurgitant blood flow. And because you have regurgitant, that's why you get the murmur, which is hollow systolic murmur. Alright? While here, this basically is really narrowed and stenosed. And when the blood comes from the stenosed orifice, this will create a murmur called diastolic rumbling murmur because it's stenosed. So here, okay, let's go back to the, So here basically diastolic rumbling murmur. Alright? Because of this stenosis. While because of regurgitant, which is A, that's why I put it under A, please. That's why I put it under A, because of this regurgitant. So this regurgitant will give you the hollow systolic murmur. Again, it's during systole. While this the blood through narrowing orifice, you can say, if you want me to write it here, narrow orifice blood flow. Because narrow orifice blood flow, you create diastolic crumbling member. You need more? Why not? What more you have, please? Go back, go up, go up. What you will see here, when you, it's rheumatic fever 25 years, so basically this is 5, while here rheumatic fever 35 or 40 years, so here basically it's another 5 comparison. I hate tables, guys. Please don't study tables. You have to compare the tables into a kind of consequences diagrams in order for you to recall it easily in the day of the test. It's 7 books, or maybe at least you can say it's 7 subjects, right? Plus several materials here and there, plus maybe first aid, plus maybe you word the questions, plus Kaplan questions, whatever, right? So you have a lot. I mean, it's really impossible for you to get all of this information the day of the test, plus the stress, plus the catecholamine levels, which is 1,000. I mean, really, it's hard. But once you will make a story, so rheumatic fever patient presented as 25 years, this is mitral regurg, while presented as 35 years, it's mitral stenosis, you're done with that. Now, you get, because of regurgitant flow, you left atrial pressure increase, and because it's regurgitant during systole, that's why it increased during systole. But when some of the blood go back down, because a lot of blood now go up, some of the blood go back down, this blood will hit some of the blood that's basically it's here, and blood hit the blood S3, while there is no S3. Left ventricular pressure is normal, left ventricular pressure is high, narrow orifice diastolic, regurgitant systolic. This is usually how you will make it. All right, I think yeah, I think that's not bad for these simple comparisons. Now, I'm not sure if I need to talk about another issues here. Yeah, there is a space. Quick issues. I know it's physio, guys, you don't like it, but also comparisons. Guys, you have to know there is a curve called ventricular function curves or left ventricular pressure curve. This is basically left ventricular pressure curve. I will talk about that in really big details in cardiac cycle. If you don't know what I'm talking about, at least get some informations. So basically, this is left ventricular pressure curve. And it's really not a big deal. I mean, although I said left ventricular pressure here and increase in mitral regurg, but this is not used to diagnose the mitral regurg or mitral stenosis. So here again, left ventricular pressure curve. And usually, maximum left ventricular pressure you get around 120, and this is usually normal. Now, the idea of the mitral disease, you will not diagnose mitral disease from left ventricular pressures. You will diagnose mitral disease from left atrial pressure. And we just discussed it. Basically, guys, this is the area from A to B is the systole. Anything between is diastole, please. That's it. Really, it's not so hard. So this is systole, and anything between is diastole. All right. Now the y-axis, sorry, the x-axis is just systole, and before that you have diastole, right? And also before that you have diastole. Maybe you didn't get full information, but this is really also higher. Now the y-axis represents pressure. So basically here maybe the pressure that you have 20, 60, right? 80, 100, and this is the 120. So these are basically the y-axis area, which is for both of these diagrams. Now, any time you are talking about mitral pathology, you will really not expect big change in the left ventricle. That's why I put the left ventricle normal 120, 120. Although I said here left ventricular pressure, don't forget please, left ventricular pressure is increased, right? It's increased, but really it's not a big deal for diagnosis. And when you are doing cardiac cath. So basically this is, maybe you will see a question during cardiac cath, and then he will give you these diagrams. Now look at the diagrams for mitral regurg. Do you remember? Yeah, that was the mitral regurg, right? The one on the left side, which is holosteric member. And we talked about mitral regurg, the regurgitant blood that hit the left atrium during, yeah, please, hopefully you remember that, during systole. And because it's during systole, that's why you will assume the pressure of the left atrium increase during systole. Usually, guys, left atrial pressure is really low. It's around 15. Look at that. Wow, started to increase during systole. Why? Because you have regurgitant flow. So this area, I'm telling you how much this is really high yield. This is basically, you will see an increased left atrial pressure. The red one, guys, is left atrial pressure area. All right. So this is basically left atrial pressure curve. The blue one is left ventricular pressure curve. If you want me to write it down, left ventricular pressure curve, which is usually not big deals. The right left atrial pressure is the one that I'm really concerned mitral pathology. So this is an increase during systole. Why, look at the second one. This is diastole, low, 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 increase during diastole, and then go back. This is almost, although maybe it's really not 100% accurate, but this is enough for you. Look at this increment during diastole. Basically, guys, it's really easy to see this kind of pictures, and then he will ask you, what is that? So basically, this is an increase left atrial pressure during systole. And because it's an increase during systole, that's why basically it's mitral regurg. That's it. Really not a big deal. Not a big deal at all, really. This is mitral regurg curve. While the other one is mitral stenosis. And why the other one is mitral stenosis? Because it's here. According to the diagram, an increased left atrial pressure during diastole. Right? Sorry. Left atrial pressure increases during diastole. So that's it. Because I told you this diastole, this is systole. And here is the mitral stenosis because it increased left atrial pressure during diastole. Why? Because it's closed. A lot of blood there, no filling. Failure to open, don't forget that. Failure to open mitral valve during diastole. Failure to close the mitral valve during systole. That's why you have mitral regurg. That's why you have left atrial, mitral regurg, which is systole. Mitral stenosis, which is diastole. Alright. Very high yield point, by the way, also. So you get really big comparisons. Excuse me. You get really big comparisons about now both of them. So we reach, I think, to the 0.5. You can now make all of that 0.6, right? Which is differential. So again, this is usually the area. Well, this is the area of the mitral stenosis. All right. Hopefully this is clear. I think I'm done with the whole. Guys, still maybe. Hey, what are the other causes of mitral regurg or stenosis, by the way? Maybe rheumatic fever we talked about. Hey, don't forget mitral regurg, acute mitral regurg. Just one question about acute mitral regurg because it's really big times. We talked about that, I think, in cardiac, in MI. Guys, MI patient, 3 days. And then after 3 days, you will hear pansystolic murmur. If you remember differential diagnosis, please, you have two differentials. You have either to think about VSD or mitral regurg. But look at this mitral regurg. This is acute, which is not the one that I was talking about. All of that we are talking about the chronic, stable kind of severe mitral regurg. This is acute mitral regurg, while this is VSD. I told you maybe the difference is whether it's radiated or not. I don't think radiation is big times. And if you remember the pathology here, this is rupture. So the problem here is rupture. Now, acute mitral regurg as a pathology, what is the rupture here basically? The rupture is just papillary, right, muscle rupture. So it's rupture problems. While guys, in case of rheumatic fever, it's usually it's not rupture pathology. Rupture pathology really acute. And this is already presented as acute pulmonary edema. Right? While the chronic mitral regurg, the one that we just discussed, it just presented as heart failure, right? Which is chronic heart failure. Yeah, by the way, there is another number for both of them. I just now remember, which is number 6. which is very easy, and we'll put it here. Now, guys, both of them presented as what? Clinical features. What are the clinical features for both of them? Shortness of breath, chronic. Or maybe you can say heart failure, which is usually as left heart failure in the beginning, and then after that, maybe they will present as right heart failure. This is really also interesting. A lot of people, when you are talking about chronic shortness of breath, oh my God, they don't know what they are talking about, chronic shortness of breath. Always chronic shortness of breath. One of the big differential is heart failure. Now, the second question is why this patient have heart failure due to the coronary artery disease. If you hear memor, this is just valvular heart disease. So both of them is really easy clinical shortness of breath, chronic left heart failure, and sooner or later lead to right heart failure if it's untreated. That's why in our patient, but right heart failure would not present as shortness of breath. Right heart failure presented as edema. Usually right heart failure presented as signs, which is edema or JVP and positive, negative ascites. All right. So this is basically for two of them. Again, go back again to the video, try to repeat it again and again. This is really high yield. Definitely these questions, guys. I told you at least 4 questions media and another 4 to 6 questions about valvular heart disease. So it's really worth it. Maybe we'll see around 10. I'm not sure now with some changes. Maybe we'll see around 10. So it's really worth it. Go over this again. And next lecture we'll do the aortic pathology. All right. Thanks a lot for watching my videos. Please subscribe, comment, send me emails. I'll be more than happy to help. All right. We'll see you tomorrow.